Hey class, welcome back to Psychology of Adjustment. We are moving into chapter 14, which you can kind of think of chapter 14, chapter 15. These are two chapters that go hand in hand. First, we're going to look at psychological disorders, how they're diagnosed, how they're conceptualized. And then in chapter 15, we're going to look at how they're treated. So you can kind of see these two as back-to-back related chapters on the same topic. So to begin with, we're going to look at the medical model that's used to explain abnormal behavior, mental illness, at least in the United States. This is the model that's primarily used in the United States and probably the Western hemisphere. Identify the key criteria of abnormality and discuss the development of the DSM-5, the Diagnostic and Statistical Manual, 5th edition, which is used for diagnostic purposes. It's a medical text used for insurance companies, doctors, to make sure everybody's on the same page. So when we think about abnormal behavior, when we think about mental illness in our country, in our way we treat mental illness is through the medical model, which really is the assumption that mental illness can be treated just like any other physical illness. There are we can use it, we can treat it as if it was a physical disease. We can use medicine, we can use surgery, we can use all kinds of medicinal purposes, techniques to relieve suffering of mental illness. And this is very much in kind of stark contrast to how we originally conceptualize mental illness. Mental illness has undergone lots of changes in how we think about it, how we diagnose it, and this kind of medical approach as to some extent, I mean, there's obviously room to grow, but you could make the case that it's really humanized patient care when it comes to mental health treatment. So, if you think about, not terribly long ago in human history, I mean, we kept people of mental illness we consider to be mentally ill, locked away from the rest of society. Nowadays, we see it's much more common for people with mental illness to get the help they need in outpatient settings where they're allowed to live and come and go as they please, live a normal life. So it's drastically changed over the years. And within this medical model, it's important, to have some table setting terms that you're aware of. The diagnosis, is distinguishing one illness from another. So, for example, distinguishing between anxiety and depression, or depression and bipolar disorder. I mean, any which way we're talking about. The etiology refers to the causation or developmental history of the illness, like what sort of biopsychosocial causes might be involved. The prognosis is the forecast of how we project the illness to progress. Whether if they're seeking treatment, hopefully we're seeing the cessation of suffering, we're seeing a good prognosis, but maybe if they're not seeking treatment or not sticking with their treatment, we might predict otherwise. So in order to diagnose, or in order to label something as abnormal, or really getting into this realm of mental illness, there's the 3Ds kind of criteria that have to be met. The first, the behavior has to be considered deviant, meaning it really stands out. It's different from what is considered acceptable by society. It also has to be maladaptive or dysfunctional, whichever one you want to use, but basically meaning it interferes with basic life functioning. Like depression, for example, like it's normal to get sad. That's fine. It's completely normal. That's part of the human range of emotions. But if you become so sad and so despondent and so depressed that you're not getting out of bed and going to class, bathing yourself, feeding yourself, all of those basic things that you need to function, that's when it starts to become dysfunctional. And then finally, personal distress. The behavior is troubling. It doesn't lead to pleasant experiences. It leads to distressful, negative emotional experiences. In the United States, we have the American Psychological Association, the APA, which creates the Diagnostic and Statistical Manual, which is now in its 5th edition. And it's a classification document. It's used to classify various disorders, providing detailed information to care providers, insurance providers, people involved in the medical field about what to expect, clinically what to expect, and also how to make consistent diagnoses to make sure when we're talking about depression, when one doctor is talking about depression to another doctor, they're on the same page. Compared to the DSM-4, we now see changes in the DSM-5. There's usually a new DSM about every 5 to 10 years, probably closer every decade. It's no longer multi-axis. Now we have this sort of dimensional approach, which looks at disorders in terms of how people score on this limited number of dimensions, basically the degree to which you exhibit anxiety. It's more of like a continuum now. So some slight changes, and also some slight changes in how different disorders are diagnosed. So now we're in the DSM-5. We're going to look at various disorders. The first set of disorders we're going to look at are anxiety and obsessive compulsive disorders, or anxiety disorders and obsessive compulsive disorder, excuse me. So we'll look at the 4 different types of anxiety disorders plus obsessive compulsive, discuss how biological factors and conditioning contribute to the etiology of these disorders, and explain how cognitive processes and stress play a role in anxiety related disorders. So anxiety disorders is this big classification. It's an umbrella of disorders that are all, they might differ in terms of the symptoms, in terms of the experience, but they all evolve around some kind of excessive worry, apprehension, anxiety, doubt, fear, any which would be appropriate. Probably the most commonly diagnosed disorder under this umbrella is generalized anxiety disorder. This is where individuals have a high level of anxiety that's not really tied to a specific threat. They're kind of anxious about anything and everything. Versus this is very different from somebody who has phobic disorder. Somebody who has a phobia has persistent anxiety, irrational fear about a very specific target, a very specific stimuli. And the thing is, it's unrealistic, meaning it probably presents no realistic danger. Like, for example, I have a family member who is deathly afraid of cotton balls. Yeah, you heard me right. Cotton balls. Like he could hold them in his hand and realize like this thing is not going to hurt me. It's not going to do anything to me. But yet, if I were to, walk towards him with a cotton ball, he'd be backing away, in fear. I would not do that, of course. But that's what I mean by it doesn't quite make sense. But yet here is this very powerful, real fear, worry, anxiety. Some other disorders in this category, we have panic disorder. This is where individuals have reoccurring panic attacks where they are overwhelmed by anxiety. Typically, sometimes these panic attacks can be triggered, sometimes not so much. So kind of figuring out what triggers those panic attacks can be really tricky. But another disorder that goes hand in hand with panic disorder is agoraphobia. Agoraphobia is not only the fear of going out into places, but it's also the fear of being in places where if you have a panic attack, it would be hard to escape. It would be hard to, to get out of that, that situation. So agoraphobia and panic disorder oftentimes goes hand in hand. Some people will, will hide from the world, so to speak. So they, using that agoraphobia as a way to kind of treat their panic disorder. These are now separated and now in the DSM-5. Previously, they went hand in hand. Now there's a pretty clear distinction. And here's an interesting comic strip, Agoraphobia Society, a nice turnout. And as you can see, there's not a lot of people there. Obsessive compulsive disorder in the DSM-4 used to be all under the same umbrella as anxiety disorders, but now it's kind of its own classification. There is still this obviously anxiety component, but now we're talking about persistent unwanted thoughts that we call obsessions. And in order to get rid of those thoughts, individuals will engage in senseless ritualistic behaviors that we call compulsions. So the obsessions are the thoughts, the compulsions are the behavior. And very common obsessions might be fear of contamination, cleanliness, harming others, suicide, sexual acts, things like that. And they engage in these compulsory ritualistic acts in order to reduce the anxiety. And, not an entirely common, not the most common disorder. I mean, we're looking at about 2 to 3% of the population, but a very debilitating disorder for those individuals. And this is just an example. When I say obsessive of cleanliness, it's one thing to prefer to be clean. I prefer to take a shower every day. I prefer to brush my teeth. I mean, things like that. We probably all have things like that. But obsessive compulsive is, hey, I need to wash my hands, 20, 30 times until I finally feel like they're clean. And now they're just raw from, scrubbing and, the soap and all that. So that's what I mean by it's getting into dysfunction. So where do these anxiety disorders come from? What is their etiology? I mean, there are biological factors. I mean, all of these disorders are going to have biopsychosocial elements to them. So for one thing, we inherit temperament in terms of how we react to the world, and anxiety disorders from our biological parents. We also have neurotransmitters like serotonin or epinephrine, GABA, for example, that are involved in the expression of anxiety or whether or not we experience anxiety. So medications might be used directly to treat at the neurotransmitter level, which we'll talk more about in chapter 15. We also we can learn anxiety, specifically phobias. We can learn via classical conditioning when to exhibit fear in a scenario and not in another. So for example, we learn how to avoid certain stimuli also through classical conditioning and operant conditioning. And it makes sense. I mean, I think there's arguments to be made that there are certain stimuli that we might be sort of biologically prepared to be afraid of. We are kind of preconditioned, like snakes, for example. Like that's something that you don't necessarily have to learn. People kind of have a natural, uneasiness maybe around snakes, spiders, things like that. So here's just an example of classical conditioning. So you have your conditioned stimulus of snow, the unconditioned stimulus of being buried in an avalanche. You pair these two together, you now associate snow with, oh my gosh, if I see snow, it makes me feel anxious. It makes me feel like I'm going to get stuck in an avalanche. And the operant conditioning reaction to this is you avoid snow. You avoid snow, and this is kind of a negative reinforcement. An example of negative reinforcement leads to reduction of fear. It reinforces that behavior. What about between our ears? What kind of cognitive factors are likely taking place? People who are experiencing anxiety disorders there is a cognitive element to it. There could be misinterpretation, seeing a situation as threatening when maybe it really isn't, focusing on those perceived threats, like not being able to stop focusing on them, recalling information selectively that's threatening. Now we're going to switch gears and look at dissociative disorders. So we will distinguish between two types of dissociative disorders, summarize what is known about the causes of dissociative disorders. So when we talk about these disorders, these are a whole class of disorders where individuals lose contact with elements of their consciousness or memory, typically resulting in some kind of disruption in their sense of identity, like who they are. One example is dissociative amnesia. This is a sudden loss of memory about personal information, like that it's way too, like, there's so much. It's not normal forgetting. It's one thing to be like, oh, I forgot where I set my keys, I forgot where I put my cell phone, but it's another thing entirely to forget your name and forget where you came from and forget how you wound up somewhere. That's the kind of memory amnesia we're talking about here. However, this is a little bit different from DID, dissociative identity disorder, also known as multiple personalities, or formerly known as. This is where an individual has multiple personalities residing in the same body that could be very different from one another. Each one might have their own name, memory, traits, physical mannerisms, vocal tones, things like that. The transition from one identity or one personality can be pretty quick, and also those differences can be really extreme in terms of, you have a 25-year-old male who all of a sudden starts acting like a 12-year-old female. That's their altered personality. Could be a different race, could be a different gender, could be a different age. So I mean, the variations are quite wide. Where do these come from? What are the etiology? Psychogenic amnesia and fugue states are usually the result of extreme stress, from trauma, from extreme anxiety. DID is also a pretty interesting disorder where the causes are largely unknown. However, there's a lot of evidence pointing towards trauma, specifically during childhood. These kinds of disorders are almost a way for us psychologically to cope and deal with high levels of stress from traumatic experiences. Could be emotional, physical, or perhaps sexual abuse even. Let's look at mood disorders now. Describe depressive and bipolar disorders, discuss their prevalence, and explain their relation to suicide. Explain how genetic, neurochemical, and neuroanatomical factors contribute to the development of depression and bipolar. Discuss how cognitive processes, interpersonal factors, and stress contribute to the development of depressive and bipolar. So basically, these are all the things you will be able to do by the end of this section. So mood disorders, really, we're talking about, it's one thing to be sad. It's one thing to be excited. But when we're talking about mood disorders, we're talking about extremes in moods. For example, with major depression, we're talking about, the lowest of the lows in terms of your emotions. It's not just being sad. Sadness is part of it, but it's this element of despair combined with lack of interest, combined with, and things that you once found pleasurable, and it becomes very difficult to even take care of yourself. Depression, it can happen at any point in time in your life, but tends to happen before 40 for most people. And, and around 13 to 16% of people, there's lifetime prevalence, meaning there's like a 13-16% chance that during your lifetime you would, possibly experience bouts of major depression. It's a very, very serious disorder. And here's kind of showing the difference between bipolar and depression. So, bipolar depression, you are literally just going from feeling normal to depressed, and you might cycle between those two experiences. Whereas somebody who is bipolar, they are going from normal to manic, the highest of the highs, and they might crash back down to depressed, back to normal, depressed, normal. I mean, so they might be fluctuating between multiple extremes. That's why it's called bipolar disorder. You are fluctuating between two polar opposites, mania and depression. So manic depression or major depression, kind of going back to that, there is some prevalence tied to gender. We see women are 2 times as likely to be diagnosed, than men are, but that's not necessarily it's not necessarily biologically there. We don't really know. We don't think there's necessarily a biological component of that, meaning like, men are biologically superior to women in this regard or anything like that. It probably has more to do with the circumstances that women endure, more stress, more abuse than men typically do. So, and also think about like who is more likely to reach out and ask for help, who's more likely to say, hey, I'm dealing with something right now. More often than not, it's probably females more than males. We're not always that great about opening up, especially when it comes to mental health. And that's not a good thing. I definitely don't think that's a good thing. Bipolar disorder, again, this is going from depressed to mania, fluctuating between those two extremes. Manic is the kind of the high highs, feeling like you're invincible, feeling very energetic. Whereas, they might suddenly crash and come back down to normal, or even feeling depressed, going from those high highs to the lowest of lows. And usually that's the time when people who are bipolar realize I need some help. When they're manic, they feel great. They feel on top of the world, and they feel like, oh, I want this to never end. And it's not until they come crashing down that they're like, oh yeah, this is not good. So here are some different, comparing and contrasting mania and depression in terms of emotion, behavior, and cognition. For the sake of time, I'm not going to go over all of this. You can pause the video right here and maybe screenshot this, or you can keep a look at it on your text. But these are, kind of how these disorders are related to one another, bipolar and depression, but obviously very different mood experiences at an emotional, behavioral, and cognitive level. Mood disorders also go hand in hand with suicide and suicidal ideation. 90% of people who complete suicide usually suffer from some type of psychological disorder, and bipolar disorder and depression disorder account for about 50 to 60% of completed suicide. So this is exactly why this is a very serious disorder. This is not something to be taken lightly. Women are 3 times more likely to attempt suicide, but men complete suicide 4 times as likely as women do. And a lot of it has to do with the methods of suicide. Men are more likely to commit suicide, attempt suicide in ways that are much more permanent, much more less likely to fail. For example, if you were to use a firearm on yourself, the probability of that not working is pretty low. Whereas if you're someone who attempting suicide, pills or some other method like that, the likelihood of the probability of it actually working is not as high. So makes sense. What about genetic vulnerabilities? We do see what's called this concordance rate, or the percentage of twin pairs. Basically looking at, okay, if you have a twin, what is the likelihood that you and your twin have, if one of you has a disorder like depression or bipolar, what is the likelihood that the other one does? And identical twins, it shows it's about 65 to 72%, compared to fraternal twins who don't have exactly the same genetic material. It's only about 14 to 19%. So genetics do matter. Like, that matters a lot. It's not the entire story, but it matters a lot. There's also, at a biological level, there are neurochemical and neuroanatomical factors that used to explain depression and bipolar disorder. Core mood disorders kind of go hand in hand with neurotransmitters, low levels like norepinephrine, serotonin. We're still a little unsure of the relationship, but we do know that these are involved somehow, but we're not quite 100% sure. Depression is also correlated with reduced volume of the hippocampus. The hippocampus, remember, is the part of our brain that is responsible for explicit memories, and it tends to be smaller in depressed individuals compared to people who are not. And so there is some theories out there sort of pointing out that maybe this idea of neurogenesis, of growth of neurons, may be a central role in regulating mood and depression. Perhaps if we could promote neurogenesis, maybe this would reduce depression in some individuals. So depression, depression, it's one thing to point to, there are all kinds, it's a biological phenomenon. It's a biopsychosocial phenomenon. So neurochemical changes can impact how we think, how we attribute and explain things, which can lead to increasing or reducing depression. So all of these factors kind of go hand in hand with one another. Cognitive factors, according to positive psychologists like Martin Seligman, we can essentially learn to be depressed. We can develop learned helplessness. If we experience failure again and again and again, we might kind of learn to give up when things are difficult. We might adopt more of a pessimistic explanatory style, thinking, oh, well, the reason why this didn't work out is because I'm a failure or I suck or blah, 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 some kind of personal flaw and personal flaw that might explain why things didn't work out. And so people, if you experience that enough times, you eventually learn to see the world through that lens. Some other explanations. The Nolan and Hoeksema also talked about rumination, this cognitive event of rumination, where we just focus on one particular thing, like, oh man, I shouldn't have said that, I shouldn't have done this, and then sort of negative thinking can spiral out of control, and that's sort of what leads to depression. Interpersonal roots also might be correlated with interpersonal factors like your social skills, how many do you have quality friends in your life? Do you have loved ones that you care about and share meaningful experiences with? But that's getting more into like correlation causation. Like, is it depression causing the poor social skills, or is poor social skills causing depression? Probably is a two-way street, in all honesty. Stress also precipitates or precedes mood disorders. The more stress we have in our lives, the more uncontrolled stress, especially, we more likely to see depression rates go up. So looking at vulnerability to depression, poor social skills are a factor, but also which could lead to, fewer reinforcers in terms of friends, things like that. It might lead to rejection, irritability. It might lead to low levels of social support. So all of these things are kind of factoring in, and also becoming depressed would also kind of factor into all of these. So it's very much an iterative relationship. Now we're going to switch gears and look at probably the most debilitating disorder, that is schizophrenia. So we'll look at describing the prevalence and symptoms of schizophrenia, positive and negative. We'll look at genetic vulnerability, neurochemical factors, and structural abnormalities in the brain as an explanation for schizophrenia, and then summarize how neurodevelopmental insults to the brain, expressed emotion, and stress contribute to the development of schizophrenia. Schizophrenic disorders, we typically think of schizophrenia as one of the few disorders that goes hand in hand with psychosis, meaning being you're out of touch with reality. Sometimes it's referred to as split mind. Really, this is a class of disorders. They kind of all fall under schizophrenic disorders, where you're talking about disruptions and disturbances in thought, emotion, perceptual, social, and social or emotional processes. It's very low. Only about 1% of the population suffers from schizophrenia. It's a very serious disorder in terms of the prognosis, in terms of it's very difficult to live with. It's probably the most debilitating disorder that we've talked about. And usually we start to see the emergence in adolescence and early adulthood as the brain continues to mature. Probably the most, identified symptom is irrational thinking, having certain delusions or false beliefs, believing that you're Jesus Christ, believing that people are out to get you, believing that your mind is being controlled is a very common one. There's also delusions of grandeur, basically believing that you're really important or famous when you're really not, again, feeding into that delusion. If you think, oh, I'm really important to the point where the CIA is chasing me and following my every move, that's what I mean by a delusion of grandeur. They might also have deteriorations of adaptive behavior, meaning they're not able to function normally. They're not able to hold down a job. They may not even be able to take care of themselves physically, emotionally, psychologically, etc. They might also be experiencing distorted perception in terms of hallucinations. Hearing things that aren't there is the most common, then followed by seeing things that aren't there. But these are sensory perceptions without the external stimuli to produce them. They might also have flat affect and disturbed emotion, which is flat affect, meaning they have no emotion in their tone, or they might display inappropriate emotions, like they might be laughing hysterically at a funeral, for example. We can divide these schizophrenia into four kind of subtypes. There's the paranoid, the catatonic, disorganized, and undifferentiated, which kind of maybe meets a little bit of all three of the above. The DSM-5 has discarded this distinction. We don't really see that anymore. Now it's more of a focus on the symptoms. You have the positive versus negative symptoms, and this does not mean good or bad. does not mean good or bad. It means addition and subtraction. So really thinking about the alternative to the schizophrenia is looking at these different kinds of symptoms. You have schizophrenia with negative symptoms, more so on the behavioral side of things, meaning they are lacking the ability to produce emotions. They might have that flat affect or that inappropriate emotions. Whereas more of the positive symptoms are things like possessing things like hallucinations, delusions, or bizarre behavior. That's what I mean. So positive is meaning they have a little, they're doing something extra in addition to what maybe somebody without schizophrenia does. Negative meaning they're lacking something like the ability to produce emotions. There is a very strong genetic componentability, meaning we see identical twins. It's about almost 50%, one in two chance of developing schizophrenia if you have an identical twin who does, compared to about 17% for fraternal twins, meaning there is a strong genetic component. There's also a link to neurochemical development. We think right now there is excessive dopamine, for example, goes kind of hand in hand with schizophrenia. There's also some studies that looked at marijuana use during adolescence that could perhaps be linked to the onset of schizophrenia. But my guess there is that that individual probably already had the genetic predisposition. So we need to be careful. We probably shouldn't say that, engage using marijuana caused schizophrenia. Maybe it didn't help anything, but it's definitely worth looking into more. So the relationship between genetics and developing schizophrenia is, the closer you are in genetic relationship. So identical twins have the same genes. It's about 1 in 2, almost 50% chance, compared to the rest of the population. It's only about 1% chance. Okay, what about the brain? CT and MRI scans have shown that there are, patients who have schizophrenia, there are some differences in terms of the brain. There's enlarged brain ventricles, compared to people who don't have schizophrenia. They're not quite sure what the result or the cause of that is in terms of, abnormal behavior, but there appears to be something going on there physically with the brain. And this can be, kind of depicted here, these ventricles depicted here. Another hypothesis trying to explain the origins of schizophrenia is the neurodevelopmental hypothesis that says, various disruptions at different points during development, during birth, to the brain, especially during and after birth, are what we could possibly point to during schizophrenia. So, for example, prenatal exposure to viral infections like the flu, malnutrition during prenatal development, any kind of complications during pregnancy are potential risks that we could use as a way of explaining the origins of schizophrenia. There's another theory, expressed emotion, basically the degree to which a relative of a schizophrenic patient displays highly or critical, overly involved attitudes towards the client. Basically, their level of expressed emotion is a good predictor about the prognosis of the disorder. Patients who end up returning to families who are very high in their expressed emotions are 2 or 3 times more likely to relapse because they add stress. That criticism, that kind of pressure, those expectations could perpetuate the disorder. These kind of precipitating stress might trigger or, kind of keep the person, someone who's already vulnerable for the disease, kind of trigger more events that make it more likely. Again, stress kind of goes hand in hand with mental illness. So anytime you add more stress to the equation, you're just making things not easier for sure. Now we're going to look at autism spectrum disorder. So you should be able to describe the symptoms and prevalence of autism, the autism spectrum disorder, and explain what is known about the causes. So autism or autism spectrum disorder is a spectrum of disorders kind of related to profound impairment of social interaction, communication, and also severely restricted interests and activities. And this is typically something we're talking about diagnosing during childhood. Symptoms may include, it's a number of things, lack of interest in other people, avoiding eye contact, failure to make emotional bonds, inability to develop speech, echolalia, where they're repeating words back. So and also they're really inflexible. Once they get into a daily routine, it's very hard to break them out of that routine. And how common is this? About 1% of children are presently diagnosed with autism spectrum disorder. However, we have seen a huge increase in the mid-90s. And however, it leads people to think, okay, well, what's causing all of this? Probably a lot of it has to do with more awareness. We are more aware of the symptoms of autism and what it means and how to diagnose it. So that probably explains a lot of that increase. However, now knowing early interventions, proper treatment, 15 to 20% of people diagnosed with autism spectrum disorder can live independently, live fairly normal lives, get a job, go to college, raise a family, all of those things. So the more we know, the better we can also help treat these individuals. So the etiology, there's a lot of debate about the origins. A lot of theories point to biological origins, genetic factors. I mean, it's a biopsychosocial phenomenon. There is sort of this myth kind of in the 1990s that emerged that, the vaccine or the mercury in vaccines that we were taking to prevent various diseases is the causal effect or caused the growth in autism. However, that research is undergone a lot of criticism, and ultimately any attempt to replicate these results have not proven to be true, and that link between vaccination and autism has proven to be fraudulent. It's just flat out not true. Personality disorders, we're going to switch gears. I think we have a couple more class of disorders to look at, then we'll call it good. Personality disorders, so we'll look at the nature and organization of personality disorders, the symptoms specifically of antisocial, borderline, and narcissistic personality disorders, as well as their etiology. So really, we're talking about dysfunction in personality. Remember, personality is our typical way of responding to the world, typical way of behaving, of thinking, of reacting. And this is where it gets into inflexible personality traits that cause a lot of dysfunction and impairment. So there's 10 personality disorders in the DSM. They are grouped around 3 kind of axioms. You have the anxious, fearful, odd, eccentric, and dramatic, impulsive. So the ones we're going to focus on primarily are antisocial, borderline, and narcissistic personality disorders, kind of giving you a little preview of everything. Antisocial, this is where individuals are impulsive, callous, manipulative, aggressive, and they don't feel bad about that. They'll hurt other people physically, emotionally, socially, whatever, and they have no regard for that person's their well-being. Borderline personality, typically. So I want to back up just a sec. Antisocial personality disorder, you're more likely to see diagnosed in men. Borderline, you're more likely to see diagnosed in women. This is typically, we're talking about instability. Instability is the key word here in relationships, social emotional functioning, self-image, really just lots of ups and downs here in terms of how they see themselves. Narcissistic personality is a grandiose sense of self-importance, really feeling like you are entitled to anything and everything, a strong need for attention, a strong need for praise. Where do these come from? Strong connection to heredity. Like all of the disorders we've talked about thus far, really strong connection to heredity. There might also be environmental factors, growing up in dysfunctional families, not being disciplined or being disciplined erratically, excessively, being neglected, amoral, not being taught morals, right or wrong, by your parents. Examples or history of being physically or sexually abused also can go hand in hand with some of these disorders. So last thing we're going to look at is understanding eating disorders. So you will be able to describe the history, prevalence, and gender distributions of eating disorders and explain how genetic factors, personality, culture, family dynamics, and disturbed thinking contribute to the development of eating disorders. Eating disorders, we're talking about severe disturbances in eating behavior. It's one thing, to maybe you're celebrating, you're like, oh, I'm celebrating, I'm going to eat a little more than normal. It's my birthday, I'm going to eat a little more than normal. That's fine, that's one thing. But now we're talking about, eating habits that are very dysfunctional, very distressful, and very deviant. So the 3 we're going to focus on are anorexia nervosa, bulimia nervosa, and binge eating disorder. Anorexia nervosa can actually kill you. I mean, no joke. This is where an individual has a very intense fear of gaining weight combined with a distorted body image, and also not recognizing that, like, oh, I am underweight and I'm doing things to continue to lose weight. You might have the restricting type where they might withhold calories. They're just simply not eating enough. And you also have the binge eating purging type where they might actually be eating a lot and then forcing the food out of their body. But either way, both kind of subtypes involve a lot of distorted body image. Even though they might be underweight, they do not see themselves that way. Like when they look in the mirror, they see themselves as needing to lose more weight. And here's an example, like with somebody with anorexia, you can physically see it. Like you can see it, which is very different from bulimia, which we'll talk about in a moment. Anorexia is very serious as a medical illness, can lead to the ceasing of menstrual cycles in women, stomach problems, dental problems. I mean, if you're purging and bring up a lot of vomit, for example, the acid in your stomach, can erode your teeth. Osteoporosis, low blood pressure, disturbances in metabolic rate can also lead to cardiac arrest. So, I mean, you can literally die from being malnourished from anorexia. Bulimia nervosa, as I mentioned earlier, anorexia, you can physically see it. Bulimia, not so much. These individuals will eat, maybe compulsively eat and overeat, but then afterwards they will purge. They will force themselves to get rid of that food. Maybe it's fasting, vomiting, laxatives, diuretics, excessive exercise, or some combination of the two. Usually these people are maintaining a normal weight. So again, it's kind of hard to see. They do have medical risks. They do present medical risks, but maybe it's a little harder to catch those because it's just not so apparent like it is with people with anorexia. Binge eating disorder is where individuals will eat compulsively, eat a lot of food, very similar to how somebody with bulimia would. However, they don't purge. They're not purging the weight away. They just have a really intense anxiety that goes with their eating habits. So these individuals might be overweight and also have body image issues where they're very upset about their body. And a lot of times this is just how they deal with stress. It's overeating in relation to stress. When stress goes up, so does caloric intake. What about the history, the prevalence? This has existed all throughout human history, but it's become more knowledgeable. We understand it more now in the 20th century. Bulimia has become more common. Young women are much more likely to develop these disorders. About 90 to 95% of cases come from women. But a lot of it has to do with we live in a culture that promotes thinness. We live in a culture that has very unrealistic standards when it comes to weight and beauty and aesthetics. Age, you're more likely to see late adolescence for anorexia, bulimia nervosa as well. What about vulnerability? Twin studies shows that there's, again, like most of these disorders, I mean, they go hand in hand with genetics. I mean, if you have a genetic relative, same, identical twin, for example, the likelihood of developing the disorder is really high. But there are other factors as well. Genetics plays a part, but it doesn't play everything. There are personality factors. There are personality factors being more rigid, being more neurotic, being more obsessive, perhaps, also scoring higher in perfectionism. Whereas individuals with bulimia, maybe it's associated more with impulsiveness, being more overly sensitive, having low self-worth, self-esteem. Again, cultural factors also explain, women are desired, thin is what is considered to be desirable in Western society. So a lot of times we associate, desirable with being thin, with our weight, and we're starting to see that kind of change. That's changing, but probably still a long way to go there. What about the family? Parents who are overly involved in their children's lives, this could be seen as a way of controlling the behavior, anorexia to control an aspect of your life. That's the one thing you can control is your weight, whereas everything else is out of your control. Mothers also might contribute to eating disorders by, for example, promoting or endorsing that obsession to be thin. If that's kind of the mood or the thought in the household, those are the messages being sent to a child, then it makes sense. What about cognitive factors? What kind of thinking might be used to explain these disorders, going hand in hand with those kind of cultural acceptance of what is considered beauty, what is considered aesthetic, having thoughts like I must be thin to be accepted. If I'm not in complete control, I'll lose all control. If I gain 1 pound, I'll be obese, things like that are the potential explanations of, at least between our ears, of what's going on. But it's a biopsychosocial phenomenon. So really it's a combination of all these things. So we're going to stop here with chapter 14. We'll pick up on chapter 15 on how we treat these different disorders. So I'll see you all around on the other side. Take care. Bye.